Good afternoon, ladies and gentlemen, boys and girls, and any animals that may be listening. Welcome to episode 8 of our CGL Sefton podcast, YouTube channel, whatever you want to call us. Today we have the fabulous Dr. Sally with us. How the bloody hell are you doing?
I'm very well, thank you, Mark. It's the weather's not so bad today.
I know, it's been shocking, hasn't it?
Oh, good for the garden.
Good for the garden. I've got artificial grass now. I know.
Shocking.
I know.
That's not good for bees, Mark. I'm shocked.
I know. I need to get some plants.
Yeah.
I want a lavender plant. That's my goal.
They smell nice, actually, and good to help you sleep.
Ah.
Put it under your pillow.
Fabulous. There's a lavender bush just across the road. I've been stealing lavender from it.
Well, you shouldn't really tell me that because I'm obliged to report it.
Oh, right, okay. I've not been stealing lavender from across the road. It's a bush that's on the public.
Oh, that's fine then.
So I've not gone into someone's garden or anything like that. So thank you for coming on. I want to ask you some questions around Buvidal. Is that okay?
That's fine, yes.
Fabulous. Okay, so to start off, if you could be an animal, what would you be and why?
Well, I would definitely be a cat.
Fabulous.
Because they're just such a wonderful life. Sleeping most of the day, out at night on the tiles. Sounds a bit like myself. The only thing I don't like is the having to catch mice.
Yeah.
I'm not a fan of the mice.
Okay. So obviously I've seen pictures of your fabulous cat before. What sort of cat would you want to be?
Exactly like him. Angus McSparkles is his name.
Angus McSparkles.
He's a fluffy rag doll.
Yes.
And he's the prince of the house. Obviously I'd be the princess.
Obviously.
But, you know.
Amazing. I love that. Love that. I would also be a cat. I'll probably be a moggy house cat, like the ones that I've got, although I've got a ragdoll as well. It's just so I can sleep all day and eat, where I don't have to catch mice either. Fabulous. So, how long have you been a doctor for?
So, I qualified in 2004, so nearly 20 years.
Wow.
Prior to that, I was a nurse.
Gosh, yeah.
So I started nursing at 18.
Okay.
Just a baby.
Just a baby.
And after 17 years of nursing, I started medical school.
Really?
Yeah, it was a big change, but in another way. I was using knowledge I already had as well. So I really enjoyed medical school.
Did you?
I was the oldest in our year, but that probably kept me young at heart.
Yes.
If not in any other way. I was a single mum at the time, so it was quite nice to have the summer holidays off, Christmas, Easter.
Yeah.
And sometimes I took the kids in to see what was going on in the...
Did you?
In the not in the hospital, obviously, but in the when we went for training sessions and things like that, which they loved.
Fabulous. Have they followed in your footsteps, or...?
Surprisingly not.
No?
They're both in languages. Yeah, my
Fabulous.
son's living in Germany, actually. Speaks fluent German, bit of French, and Zoe is Spanish and Portuguese.
Amazing. Clever kids.
They are.
Clever mum. Did you find it hard as a single mum being in medical school as well?
A little bit, but on the other hand, the hours were better than working.
Yeah.
The main issue was financial. You know, it was difficult financially, but then you just have to take out lots of loans.
Really?
And pay them off when you qualify. So.
Absolutely. So how many years is medical school?
So normally it's 5 years.
Yeah.
Just pure medical school, and then you continue your training once you start work as a junior doctor. But if you've already got an undergraduate degree, now you can do it in 4 years.
Wow.
So that shortens it a little bit. But obviously you've already done 3 years in one degree and then 4 years at medicine, so it's 7.
Yeah.
But you only really start learning once you get on the wards as
Once
a
you get
junior
on the
doctor.
wards.
Yeah.
And you have to go onto the wards as a junior doctor. Could you not do that in like a GP surgery, or is it? How does it work?
You do both.
Do
these
both.
days. Yeah. So you have to do some training on pretty much all aspects of medicine, from medicine, surgery, psychiatry, obstetrics and gynecology, paediatrics, general practice.
Wow.
Mental health. Well, I said psychiatry, but you can go on the community. There's a lot you can do. It's a very varied job. And I would recommend it to anyone because it can take you around the world as well as anywhere in the country.
Do you find, because I know every time I see you, because I'm a bit of a hypochondriac, I say, check this, I've got a cough, I've got whichever. Do you find that people come to you constantly?
I wouldn't say constantly, but you do get it, or phone calls off your friends and family.
Yeah.
And you've got to be really careful because it's not always appropriate to give medical advice to people who aren't your patient.
Yeah.
So I can give general advice, but if I've got any concerns, I would obviously signpost people to their own GP.
To their own GP, yeah. Amazing. Well, I apologise every time I see you for checking this or that ailment. Amazing. Okay, so obviously we're going to do this session about Buvidal, and I will, hopefully, time permitting for yourself, and get you back to discuss other things in the future. But Buvidal, I don't know a lot of information about it, so I thought the people who are listening may not know a lot either. So perhaps you could offer some more information around what it is, what it does, what we offer.
Okay, so I think most people would know that if you have a problem with opiates, any individual with a problem of opiate dependence or opiate addiction can come into CGL or any other drug treatment service and be offered a range of treatments, usually methadone or buprenorphine, and there are different forms of buprenorphine. So methadone is methadone, to be honest, it's straightforward.
Yeah.
It's 1 milligram in 1 ml, it's a green liquid, pretty much everyone knows what that is. And that works to replace the opiate that people are having a problem with. Buprenorphine is a little bit more flexible and it comes in a variety of forms.
Okay.
So the main one we've prescribed in the past has been a tablet that goes under the tongue and it dissolves.
Is that Subutex?
That was the old brand name,
okay.
But we tend to call it buprenorphine because that's the generic name. Subutex is a brand.
Ah, right, okay.
But you're right, some people still refer to it as Subutex or even Subbies.
Subbies, yeah.
Yeah, you've heard of Subbies. So there's that, but there's other forms of buprenorphine as well. So it comes in combination with naloxone. That's the trade name for that is Suboxone. Similar tablet goes under the tongue. The advantage of buprenorphine over methadone is that buprenorphine can actually block other opiates. Okay. So it means that you can't use opiates while you're taking buprenorphine, or it's not that you can't, it's much more difficult. You won't get an effect from them, so it's a waste of time, energy, money, whatever. So it's for people who are really serious about their addiction and really want to stop using the opiate of choice that they're using. So that's Suboxone and Subutex or buprenorphine and buprenorphine with naloxone. Then they developed a different form of buprenorphine, which is called Espranor.
Yeah. Again,
it's another tablet, but this time it goes on the tongue instead of under the tongue, and it dissolves a lot more quickly. So some people prefer that because, waiting 15 to 20 minutes for a tablet to dissolve under the tongue can be a pain.
Yeah.
So this new one goes on the tongue, dissolves in seconds.
Okay.
And then, in the last few years, this new form of buprenorphine has been developed, which is the injectable form. So we'd call that a depot injection, which means that you only need to have it once a month.
That's amazing.
And if you think about the advantages of that, you're not having to go to the pharmacy to pick up your prescription. In some cases, people are going daily, as you know, which can be very disruptive on their time. Holidays, that revolutionises holidays. You don't have to pack medication, take it with you. It's got a lot of advantages. It has all the positive qualities of the buprenorphine tablets and added advantages of, the convenience. In some cases, people actually think they forget they're on treatment because they've had their injection, they feel well. Yeah. Another advantage is that the level of buprenorphine in your body is staying at more of a steady state. It's not going up and down like it does when you're taking tablets, particularly if you don't take them regularly. Yeah. So it's got a lot of advantages, and some people are a little bit fearful of the disadvantages. And really the main one is the pain of the injection. If you don't like needles, you're not really going to particularly want this. It is a bit painful, like any injection is. Yeah. But when you think about it, it's just once a month. You can do that for once a month. We've got fabulous nurses here who know what they're doing. Yeah. They give the injection, look after you, stay in the building for 15 minutes, give you a cup of coffee or tea afterwards. Yeah. So I just really think it's a very positive move in substance use disorder treatment.
That's absolutely amazing. So whereabouts does the injection go?
So it can go in a number of sites, and you do have to rotate the sites.
Okay.
Like, you wouldn't want to put it in the same place within 8 weeks. So it can go in the tummy, it can go in the top of the arms or the top of the legs, or it can even go in the buttocks.
Right.
And it's partly up to the service user's choice,
Okay.
and partly obviously with the advice from the nurse.
Amazing. So are there any side effects to it?
Some people, when they first start it, have mentioned headache,
Okay.
but usually that resolves with paracetamol, and it's usually a short-term thing, less than 24 hours. You can get pain at the injection site.
Okay.
That can last a day. But they're all rare, side effects are rare, and there aren't many people who can't have the injection.
Really?
If you've got very severe liver disease, and I mean very severe, then that, I'm afraid, you can't have it then. But even if you've got mild liver disease, or if you've got any other conditions, we'll have a little chat to you. We'll see what's going on, because a lot of people have either heart conditions or lung conditions, and they worry that they might not be able to take this medication. But they'll come and see one of our prescribers, myself or one of the others, and we can tell them if it's right for them.
Amazing. So would we do the bloods here, and then you would get the results, you would check them and say, right, this person can or can't.
Yeah.
Fabulous.
That's absolutely right. We have to look at the bloods before they can have the first injection. But just a word of caution: the first injection is usually a weekly one,
Okay.
and that's just to make sure that there aren't any side effects, that the service user likes it, that they're suitable to move forward, and then a week later they start on the monthly injection. Different services do it slightly differently. Some people give 4 weeks of weekly injections before going on to the monthly, and we would sometimes do that as well if there was any, fears of adverse effects. But on the whole, it's 1 weekly, then the monthly, and then they go on to have it every month.
Amazing. And do you find that people are opting for that more now, or do you still find that people are wanting to stay on the script because they want to use on top, or what's been the general thought process around here?
I find that initially when we started doing it, there was a reluctance, because I think just because people didn't know much about it.
Yeah.
But now we're getting more and more people interested, which is great. When you talk about people wanting to use on top, I'm not sure if it's necessarily a want, or whether it's that they're not yet in a position to stop using.
Yeah.
Or don't know what that feels like and haven't had the opportunity. But we love to talk to people about that, because there are different things we can do. For example, they might go to an inpatient detox to absolutely stabilise their use before they decide to then go on to buprenorphine.
Of course, yeah.
And then Buvidal. So there are a lot of options. It's open to everybody who's decided, made a positive decision to try something new. So
would this be open then for people who have like a codeine addiction? Would you put somebody on Buvidal? So, because before I started working in this service, I saw clients come in and they were on methadone, for example, because they were addicted to Zappine.
Yeah.
So would you put clients, or is it a case-by-case basis?
It's definitely a case-by-case basis.
Yeah.
In general, we tend to not really want to treat people with codeine issues with OST or opiate substitute therapy. We will usually work with the GP to do a reduction in the community.
Okay.
Having said that, there are some people who are buying them illicitly or taking very large amounts, and the safest thing to do is get them on the OST. So really, it's not a question of what their primary drug of addiction is, it's where they are in their treatment. So if they're already with us and they're on methadone or on buprenorphine tablets, they're suitable to have the discussion for Buvidal.
Okay, that makes sense. You can tell I don't work on the opiate team, can't you? So with methadone and I still want to say Subutex, when I used to work on an opiate team, that's what we used to call them. With buprenorphine, you do a reduction, so you're on like 70 mils of meth, for example, you do a reduction slowly but surely. With Buvidal, is it a case of you've been on it for this amount of time and the client then says, you know what, I'm ready to try life without it? or is there a reduction on milligrams that you inject?
So it's really, excuse me, interesting that there's a number of options. So some people will just decide that's it, they've had enough, and they don't turn up for their next injection, and it gradually comes out of the body. That's how it works. You'll test somebody's urine almost up to 6 months down the line. It might still be faintly positive for buprenorphine because it's coming out so slowly. But what we would, if we were planning it, what we would do is get them down to the lowest monthly dose, which is 64 milligrams, and then suggest they miss the next one. But that's not to say that then if they start to worry or feel anything from that we'd leave them alone, we'd bring them back.
Yeah.
And there's other options.
Brilliant. So with every client that comes through our doors here, we issue with naloxone, don't we?
Yeah.
So people that don't know, obviously naloxone is a blocker if somebody has gone over. In an overdose, you can give an injection. We'll do another session on naloxone.
Yeah.
So would we still issue as a precaution naloxone to Buvidal clients as well?
Absolutely.
Yeah, absolutely.
It goes to everybody, because don't forget, the purpose of issuing naloxone really is not for the individual to use on themselves. It's for them to use with if they find themselves in the presence of someone else who may have overdosed.
Yeah.
Sometimes, as you know, Mark, people use other drugs.
Yes.
And some people still do try and use opiates on top of Buvidal. So obviously it's quite difficult to reverse Buvidal because it's a long-acting medication that's in the body, but any other opiates that happen to be in the system can be reversed.
Okay.
And I would give naloxone to everybody. You know me, I'd give it out to everybody in the street
absolutely.
if we could. So yes, the short answer is yes. Give them the naloxone kit.
Fabulous.
Yeah.
Last question then around that. So if somebody is on Buvidal and they have back pain, and then the GP tries to prescribe Zapain, for example, which is an opiate, and the client then goes to take it, what's the side effects of them trying to take that opiate on top of the injection of Buvidal?
Okay, so it probably just won't have as much effect as it would normally do for somebody like you or I. If we took a Zapain, probably have a lovely long sleep. So there's just no point in it really. And one of the things we do is issue a card that the person keeps in the purse or the wallet, and advise them if ever they're seeing a doctor, whether it be the GP, A&E, walk-in centre, whatever, to let that doctor know that they're on the Buvidal injection. Fabulous. And they can provide an alternative painkiller to it, no opiates.
Yeah, it's amazing.
It is. I love it.
I think, absolutely phenomenal. Is there anything else around Buvidal that you think people need to know? Anything that I've not covered? We're not working on the opiate team.
Well, one of the things we're doing here, we're actually looking at how it affects people's health and well-being.
Okay. Because
there is some evidence that buprenorphine generally is better for people with respiratory disease, so things like asthma and COPD. So it's better than methadone. So we're looking at that, and we're also looking at how it impacts on their life. Yeah. Because we said before, the convenience is better, they can go on holidays, and all these things have knock-on effects, whether people can go get into work, education and training, whether they can have better relationships with their families and friends, not constantly thinking all the time, I'm on a script, I've got to get to the pharmacy, that sort of thing, that's gone. So that's the biggest thing for me. I think it really does improve people's quality of life, and that's what we're here for, isn't it? To help people just get on with their lives and put that addiction behind them. Yeah,
and what I love about you, Dr. Sally, is I've obviously sat in on with people that have been on leave or whichever. I've sat in with some opiate clients. There's never any judgment from you. You speak to the client the same way you speak to me or the next person. With some doctors in other services that I've worked with, it's very it's a very different approach, and I know that the clients, because the feedback that you get, amazing, they really appreciate it. It's really nice to see. It's absolutely the truth. Okay then, so what advice would you give someone then who wanted to get into the medical field, either nursing or they have aspirations to be a doctor?
I would definitely say try and get yourself into some voluntary work or even just a shadowing opportunity, whether it's in a nursing home or a hospital or a service like CGL.
Yeah.
Because you don't know until you're in it whether you're going to like it. I did get a big shock when I went into nursing at 18 because I hadn't done any of that.
Mm-hmm.
Having said that, I took to it like a duck to water and I was really glad, but I was surprised at the responsibility that the healthcare professionals have for other people's lives and how important it is to take it seriously, treat patients as if they were your own mother or whatever, or how you would want your own mother to be treated. And once you get into that mindset, you can just really enjoy it and feel like you know, putting something valuable into the community.
100%. I bet in your time, and I'm sure you can't say, but I bet in your time of being a nurse and because you're a GP as well, aren't you?
Yeah.
I bet you've seen it all from every body part to every sort of story and everything.
Probably. Maybe I should write a book.
I think you should. Keep it all anonymous and write the book.
You might feature in it, Mark.
Oh my God. with me being a hypochondriac or Munchausen. Is that what it's called, isn't it? And Munchausen by proxy, that's when you...
That's when you take someone else, like a child, into the hospital and pretend they're ill.
Yeah, have you ever seen that film? Or it's not a film, it's it was like a series called The Act about Gypsy Rose Blanchard.
No.
So it's about the mother in America, the Gypsy Rose, the child. She's getting out of prison this year, and she ends up, I won't tell you what happened, but she ends up in prison, and her mother had Munchausen by proxy, and the things she used to do to this child, she was peg-fed and all sorts. It was shocking. I
have seen that as a nurse. Not peg-fed, but I've seen a Munchausen by proxy case in Alder Hay Hospital.
Really?
Many years ago.
Shocking. Okay, so obviously the stress of this job, I can imagine the stress that you're under. And what do you like to do in your spare time?
I've got a few little hobbies, apart from stroking my little Angus.
Angus, what's he called?
Angus McSparkle.
Angus. So when you're in the vet, let me ask this question first. Does the vet say Angus or does he say Angus McSparkle?
Gets the full name.
I love that. I absolutely love that.
Everybody looks round and, expects to see this tiny little thing and they've got a great big fat cat.
Yeah.
So yeah, he's obviously a big... I've got to brush him and things like that. Yeah. I like crochet. I've only just learnt last year to crochet.
Go away.
My sister taught me, so I make little animals.
Yeah.
I have a Harley Davidson motorbike, which I like to ride around.
Yes.
And I've been to a lot of, I like MotoGP, for example, so I've been to a lot of bike racing.
Yeah.
And ridden the bike around Spain and around Texas.
Oh
Not
my
bike
God.
to Texas, I had to hire one out there, but
yeah,
rode a Harley in Texas. And what other hobbies? I like reading, mainly true crime or crime thrillers generally.
Yeah.
And plants, I like growing plants. I've got loads of hobbies, I never stop.
You don't stop, do you? Okay, so where, either the places that you've been or where you would like to go, where's your ideal destination for a holiday?
I love Spain because I do speak a little bit of Spanish and I'm trying, because I lived in Gibraltar for 3 years.
Okay.
So I had to learn a bit of Spanish because some people in Gibraltar, that's their first language.
Okay.
So yeah, I love going to Spain because then I can show off.
Yeah.
Ask for the bill in Spanish and things like
Love
that. Love Italy.
Yes.
Recently come back from Tuscany, that was beautiful, mountainous and
I've seen the pictures.
Gorgeous.
It's gorgeous.
But I love travelling. I've been many places and I will, if you offer me a holiday, I'll go anywhere. Pretty much anywhere. I mean, obviously I don't want to go somewhere where there's any trouble.
No,
but,
or Blackpool.
Hey, there's nice places in Blackpool.
There is.
Yeah, so, I'm going to Lake District actually this weekend, so I love the lakes as well.
Bloody hell, you never stop.
I know.
I love it. Okay, can you say 5 things about yourself that best describe you?
I think I'm tenacious.
Okay.
But also stubborn. That's not such a good thing, is it? We're thinking positive here, aren't we?
Yeah, you're positive. 5 positive things.
Okay, I think friendly.
Yes.
Approachable. Non-judgmental, which you touched on. Tenacious and... what else? Rock the DMs.
You do rock the DMs, don't you? I love it. Please, may I say 5 positive things about you?
Oh, go on.
Well, I'm glad you said yes, because I was going to do it anyway. So, yeah, you're most definitely friendly, you're helpful, intelligent, rocking the DMs. I absolutely love the fashion sense, and I love how kind and caring you are, not just to the patients that walk through the door, but to staff members as well. When I say there's no judgment from you, you know, you don't look your nose down at us because you're the doctor and we're not. It's you treat us like you would treat one of your colleagues who is a doctor, and you don't often get that. So thank you for that, Dr. Sally.
Thank you for that feedback. It's appreciated.
Absolutely, and it's the bloody truth. Thank you so much for your time.
Anytime.
And I will definitely get you on again.
Love it. Come back anytime.
Fabulous. Have a nice day.
And you.
Bye.